topic of my presentation is narrowband imaging for colorectal lesions. So narrowband imaging is a type of image-enhanced endoscopy which enables us to see the mucosal surface in greater detail and helps in identifying early lesions as well as predicting the nature of lesions in real time. So before we can identify an abnormality, we need to know what the normal appearance is. And in this session, we are covering colon. So in colon, the surface pattern appears as round white structures, as you can see in this picture. And surrounding the white structures are the brown structures, the brown lines in a honeycomb pattern. These are the microvessels. So we have the round white structures, which are the surface pattern, and the brown structures in a honeycomb pattern, which is the vascular pattern. So the main applications of narrowband imaging in colon are characterization of polyps, that is identifying whether the polyp is adenomatous, malignant or hypoplastic, screening colonoscopy to detect more number of lesions, surveillance of patients with inflammatory bowel disease, and also during a therapeutic endoscopic procedure like EMR or ESD, we want to ensure that there is an adequate margin of normal tissue around the lesion which has been resected, and NBI can help us in assessing adequate margin of resection as well. So first we'll discuss about characterization of polyps. This is one area where a lot of work has been done on NBI in colorectal lesions. So when we say characterization, it means we want to identify whether the polyp is adenomatous, hypoplastic, or is it malignant. Okay. And what is the importance of real-time characterization of polyps? So obviously we know colonoscopy is an invasive procedure, and when we're doing a colonoscopy, if we come across polyps, then we need to remove them so that the patient doesn't have to have another procedure. Now, the therapy also depends on the nature of lesion. For example, if you have a polyp which is adenomatous, then it can be resected endoscopically. However, if it's a polyp which has got features of invasive carcinoma, then that person has to go for surgical therapy. And NBI can help us in differentiating these two types of lesions. Another situation which is not uncommon is that we are doing colonoscopy and we have done polypectomy, but somehow the specimen is lost either in the stool sample or it is lost in the suction. And so we don't know what the nature of polyp was. And as we know that if somebody has an adenomatous polyp, especially of particular size, then the person needs surveillance in futures. So if you could, based on NBI, make out that what that polyp likely was, then we can make a plan in terms of the surveillance interval. So next we'll discuss how do we characterize the polyp. So on NBI, we are interested in knowing the surface pattern and the vascular pattern. And based on these patterns, we make a judgment as to what is the most likely pathology is. So for surface pattern, the kudos fit pattern is actually very helpful. In fact, this was developed even before NBI was in practice. And based on kudos fit pattern, which is the surface pattern alone, we can make assessment about the type of polyp to a good extent. So therefore, it's very important to be familiar with this kudos pit pattern. Okay, and there are these different types of pits. So the type 1 is the round pits, which you see in a normal colorectal mucosa. Type 2 is stellar or papillary pits, which are seen in hyperplastic or non-neoplastic polyps. Type 3 is of two types, 3L and 3S. 3L is the more commonly observed type. So in type 3, the pits are tubular or round. In 3L, they are large tubular, or the round pits are larger than a normal mucosa. In type 3S, they are small tubular, or if they are round, then they are smaller than the normal round pits in the normal mucosa. Okay, in type 4, instead of tubular, now there are branches as well. So this is branch-like or gyrus pits. So type 3 and 4 denote adenomatous polyp. Okay, and in type 5, the polyps do not have any definite structure. These are called non-structural pits. So based on these patterns alone, you can make judgment as to the likely nature of polyp. So if it is type 3 or 4, then the polyp is likely to be adenomatous. If it is type 5, then it's probably an invasive carcinoma, and this patient needs to be referred for surgical management. So next we move on to the vascular pattern and how the surface pattern and vascular pattern is combined together to reach a conclusion about the type of polyp. So One of the popular classification which is available for colorectal polyps is the NICE classification, which stands for NBI International Colorectal Endoscopy Classification. This divides polyps into three types: type 1, type 2 and type 3. And they're looking at the color of lesion, the vessel and the surface pattern. The surface pattern we've already discussed in the previous slide. In terms of vessel, in type 1, you may not see any vessel or there may be isolated lacy vessels. Whereas in type 2, the vessels are much more prominent in brown, as you can see in the middle figure. Okay, so these are brown vessels which surround the white structure. The white structures are the pits or the surface pattern. In type 3, there are areas of disrupted or missing vessels. Okay, so this is the vascular pattern. And in terms of color, in type 1, the color is same as background or lighter than the background mucosa. Whereas in type 2 and 3, the color is darker than the background mucosa. Okay, so when you combine the features of color, vessel and surface pattern, then in type 1, as I said, you have lighter or same color as background. The vessels are not visible or they're isolated lacy vessels. In surface pattern, you have dark or white spots, okay, of uniform size. Whereas in type 2, the color is browner relative to background. The vessels also, they are prominent brown vessels surrounding the white structures. And the surface pattern is Kudo type 3 and 4, which is oval, tubular or branched. Okay. And in type 3, again, the color is browner relative to background. And the vessels, there are areas of disrupted or missing vessels. And even surface pattern, there are absent surface pattern or amorphous surface pattern. Okay. Now, one of the limitations of NICE classification is that type 2 lesions may be low-grade dysplasia, high-grade dysplasia, superficial cancer, and it is not able to differentiate between these types of lesions, and they do have a bearing in terms of therapy. So to improve upon this, there is this JNET classification, okay, and this JNET classification divides the type 2 lesion into 2A and 2B. So in this slide, just focus on the 2A and 2B. The 1 and 3 is same as the NICE classification. So in 2A, the lesion is likely to be low-grade adenoma, whereas in 2B, it's high-grade adenoma. So in 2A, the vascular pattern, the distribution is regular. Okay, surface pattern, again, the distribution is regular. Whereas in 2B, there are areas of irregular vessels and distorted vessels, and the surface pattern is irregular. So that's how you differentiate between 2A and 2B. However, studies have shown that this 2A and 2B differentiation is not very accurate in real-time clinical practice. So that was about the identification of lesion as hyperplastic polyp, adenomatous polyp or carcinoma based on NBI. And now I'll show you some examples. So in this picture, if you see, on the left hand side is a white light image of a polyp, and on the right hand side is the image on NBI. And you can see the color is same as the background. There are some dark spots and the vessels are very faintly visible. So this is an example of type 1 or hyperplastic polyp. Now look at this picture here. Straight away you can see that the surface pattern, you can see tubular structures. Some of them have branching as well. And surrounding these white tubular structures are these brown structures or the blood vessels. Okay, but there is no irregularity in the vessel or the surface. So this is a type 2 lesion on the NICE classification or type 2A by the JNET classification. This denotes an adenomatous polyp. If you look at this picture again, you see the white surface, there is tubular, and in some areas they are branching as well. The vessels, again, they are dark brown structures, much more prominent than in the type 1. And in the center of lesion, there are areas with irregular vessels actually. So once you see this sort of feature, this will still be a type 2 lesion on NICE classification, but on JNET, this will be type 2B. So this is an adenomatous polyp with high-grade dysplasia. And finally, we have the type 3 lesions. If you look at the image here on the right-hand side, you see NBI image of a colorectal polyp. And you can see that there are areas of disrupted vessels. The surface pattern is not seen, it's amorphous. And this is an example of a malignant polyp. Okay, so just by looking at NBI, we are able to decide different types of polyps, and this greatly helps us in making therapeutic decisions in real time and avoiding waiting for a biopsy and then repeating the procedure again. So having discussed the way of identifying different types of polyps, what does the literature say about the utility of NBI in differentiating neoplastic from non-neoplastic polyps? There are a number of studies, And this meta-analysis with 28 studies and more than 6,000 polyps has shown a very good sensitivity and specificity of NBI in differentiating neoplastic from non-neoplastic polyps. And what the authors have said that if the surveillance intervals were based just on NBI appearance, more than 90% of times the decision would have been correct. So that's what I meant when I said that sometimes when you're doing a polypectomy and you lose the specimen, then still if you had an NBI picture, you'll be able to make out that this was most likely an adenomatous polyp and this patient requires surveillance at this particular time interval. While we talk about the polyps as being hyperplastic or adenomatous or carcinoma, there is another type of polyp which we need to remember. This is the sessile serrated adenoma. Now, this polyp, it appears like a hyperplastic polyp on NBI, but this has the malignant potential of an adenoma. And that's one of the limitations of the NBI classification of type 1 lesion, because type 1 can be both a hyperplastic polyp or it can be a sessile serrated adenoma. Now, if it's SSA, then the lesion has to be removed. Okay, so now there has been quite a bit of interest in this particular area, and few features are emerging which can help us in predicting that the polyp is most likely to be a sessile serrated adenoma. So these features include a clouded surface, as you can see in image A. Then the border may not be very distinct from the surrounding mucosa as seen in image B. The surface may have irregularity, which you can see in image C. And finally, there may be dark spots inside the crypts as you see in the image D. So if you have two of these four features, then this has been shown to be quite good in predicting sessile serrated adenoma. So before I discuss about the next indication, that is surveillance of colonic polyps, I would just like to summarize what I have said so far. So narrowband imaging helps us to assess the mucosal lesions in greater detail in real time and make prediction about the underlying pathology. For colorectal polyps, based on the surface pattern, the vascular pattern, and the color of lesions, we can divide them into type 1, which is hyperplastic, type 2, which is adenomatous, and type 3, which is a carcinoma. And this can help us in making therapeutic decisions in real time. Now, the next thing is surveillance of colonic polyp. So it's natural to think that you have an image enhanced endoscopy which looks at the mucosa in great detail. So you should be picking up more colonic polyps. Now, as you know that in the West, there is a surveillance colonoscopy or a flexible sigmoidoscopy for patients of the age of 50 years. And so does NBI pick up more adenomatous lesions compared to a white light endoscopy? So the earlier studies were not very encouraging. The NBI was shown to be as good and not better than a white light imaging. However, with improvement in technology and better processor and better quality of images, the situation is changing. And this is the most recent meta-analysis. This is an individual patient level meta-analysis published in Gastroenterology. And here they have looked at white light endoscopy versus narrowband imaging for picking up colonic adenomatous lesions. Okay, and what they found is that overall there is a benefit of NBI with a p-value of 0.04, and this benefit is much more apparent when the bowel preparation is very good. So obviously you need to have good bowel preparation to pick up the subtle or the small lesions. Okay, so based on current evidence, we can say that NBI is better than white light endoscopy in surveillance of lesions as well. Another area of application in surveillance is surveillance of patients with inflammatory bowel disease. So what are the limitations of surveillance with a white light endoscopy? Now, dysplastic lesions in IBD may be flat or subtle and may not be easy to visualize on white light endoscopy. The random biopsy which is recommended, the yield is very poor because each biopsy only covers a very small amount of colonic surface area. And data suggests that patients who've had surveillance, even in them there is a significant rate of cancer, which means that lesions were missed. Okay, and due to these limitations, there is a need for better technique and also need for targeted biopsy instead of random biopsy. This slide again tells you the very poor yield of random biopsies. If you can see this first study, about 2,700 biopsies taken and only one positive lesion. Similarly, other studies as well where a lot of mucosal biopsies, random biopsies are taken, but the yield is quite poor. So how can we improve the detection of dysplastic lesions in IBD? So one is we can use a high definition endoscopy instead of a white light endoscopy. Second is using a chromoendoscopy. In fact, chromoendoscopy has been shown to improve the yield, and currently this is the recommended method for surveillance in patients with uh, colitis. However, there are limitations that it takes more time, and sometimes the dye spray may not be uniform. Okay, so therefore we have NBI, which is also a form of chromoendoscopy, but it is a digital chromoendoscopy. So this does not require a dye to be sprayed. Okay, so how do we detect dysplastic lesion on narrowband imaging? Now again, the data on this is very limited as of now. Okay, the important requirements are that disease should be in remission. That is for any modality of imaging. You look for any flat or elevated lesion. Once you identify a lesion, then you look at the surface pattern. And if the surface pattern is of the kudos type 3 or 5, 3 to 5, which I had discussed earlier, then that denotes a dysplastic or a malignant lesion. Okay, and obviously these lesions will have increased or abnormal vascularity, but the key feature is that the disease should be under remission, and then the surface pattern should be between 3 to 5. So if you look at this particular example, now on the left hand side you have an NBI image with a normal focus, and you can see some dark areas. We don't know what these areas are, but on the right hand side it's a near focus image of the same area, and what you can see that the round white surface is still maintained. So the round pattern is type 1, not type 3, and therefore this is not a dysplastic lesion. In fact, the dark color is because of the brown structures around the white structures, the blood vessels, they are congested, but there is no change in the pit pattern, so therefore there is no dysplasia. In comparison, if you look at this image, you can straight away appreciate there are tubular and branched pits, which is kudos type 3 or 4, and so this is an example of a dysplastic lesion in ulcerative colitis. So what does the literature say about narrowband imaging in surveillance of patients with inflammatory bowel disease? So overall, as of now, there is no benefit of narrowband imaging over a white light endoscopy or a high definition white light endoscopy. So for white light endoscopy, there are only 2 studies, and there is a trend towards benefit of NBI, but this has not reached statistical significance, maybe because of the small number of studies. For white light high definition imaging and NBI, as you see in the middle part of the image, there is not much of difference. But there have been more studies of NBI versus chromoendoscopy, and this result is interesting. If you compare NBI with chromoendoscopy, there is no difference. In fact, the confidence interval is almost 0.69 to 1.51. And currently, chromoendoscopy is what is recommended. So if NBI is no difference and as good as a chromoendoscopy, and therefore instead of a dye spray chromoendoscopy, a digital chromoendoscopy like NBI is an option in these patients. Now the final indication is to delineate that adequate margin of the lesion has been resected during EMR or EST. Now this is again important because if you leave behind lesion, then the therapy is incomplete. There is a risk of recurrence of lesion and the patient may have to have further therapy. So this is an example of one of the lesions we saw a few months ago. If you look on the right hand side, there is a laterally spreading lesion in the colon, and when you're going to do a EST for this, you want to ensure that adequate margin has been covered. So NBI can help us in looking at the surface pattern and make sure that the margin does not include any lesion which has been left behind, as you can see on the right side figure. So with that, I come to the end of my presentations. So to summarize, narrowband imaging is a mode of image enhanced endoscopy which helps us in characterizing the lesion, predicting the underlying nature, and making therapeutic decisions. Currently, the main benefit is in characterization of colonic polyps. There are emerging evidence to say that it may be beneficial in surveillance of colonic polyps as well. The data for surveillance of IBD is not there as yet, but it has been shown to be as good as a dye spray chromoendoscopy. And finally, NBI can be helpful in delineating the margin of lesions during EMR and EST. With that, I come to the end of my presentations. Thank you for your attention.
Very good afternoon. Let me first thank the organizers for giving me this opportunity. I'm Dr. Roy J. Mukkada. I'm the Director of GI Endoscopy and Senior Consultant and Head of Gastroenterology in VPS Lakeshore Hospital, Kochi. I know it is a very difficult task the organizers of the Endocon have done. Thank you so much. And the topic given to me is EMR or ESD. How far can we go as an endoscopist? So let's take a look into a few points before we go into the talk. So you should pick the right lesions and the right procedure. And before you start, you should know your limits. Avoid complications, and if at all there are complications, you must learn how to manage it, and you should always be worried about the recurrence. So when the EMR and ESD both are established, yes, yet distinct techniques for the treatment of superficial GI neoplasia. EMR is simpler and faster, but it's limited by its ability to resect large lesions and block. So the limitations of piecemeal EMR of large lesions is the high rate of recurrence and less than ideal tissue specimen for accurate histologic evaluation. So, but regarding ESD, it allows the en bloc resection regardless of the lesion size, reducing the risk of recurrence and facilitates precise histologic staging. However, it takes a longer time and it's technically more complex. It's always associated with a higher rate of adverse events. So the ESD guidelines say the majority of colonic and rectal superficial lesions can be effectively removed in a curative way by standard polypectomy and or by EMR, whereas ESD is mainly used when there is a high suspicion of limited submucosal invasion based on the depressed morphology, irregular or non-granular surface pattern, and especially if the lesions are larger than 2 centimeters, the lesions that cannot be optimally and radically removed by snare-based techniques. So if you remove a lesion by EMR en bloc, the local recurrence is only 3%. But if you remove it by piecemeal, the recurrence rate is around 20%. So the recurrences that were treated with APC and or EMR, again the recurrence rate was 21%. If a large adenoma more than 15 millimeters is removed in a piecemeal fashion, patients should have a repeat colonoscopy in 6 to 12 months to evaluate for local recurrence. So EMR should not be attempted for a non-lifting lesion or lesions classified as Paris 2C or 3. A word about non-lifting sign. When you inject to the normal submucosa, there should be a lift. So here you can see on the right side, the lesion is not lifting up. So in mucosal lesions, if non-lifting sign is positive or if the lesion is residual or recurrence lesions, ESD should be done, not EMR. And en bloc, because en bloc resection is desirable and EMR is difficult, especially in suspected early carcinoma or laterally spreading tumor of a non-granular variety. So non-lifting sign, but also you must be careful that non-lifting sign should not be assessed for lesions who have had a previous biopsy or lesions at the site of previous biopsy. Residual tissue after previous mucosectomy also. Now, regarding the safety issues, there is the intra-procedural bleeding rates is around 11% and 22%, especially if the lesions are more than 20 millimeters. So which can be tackled with tip of the snare, hot biopsy forceps, monopolar hemostatic forceps, APC, clips, etc. The risk factors for intra-procedural bleeding is mainly the lesion size and Paris classification of 2A or 1S, tubulovillous or villous histology, and low volume centers. Risk factors significant post-procedural bleeding is the proximal colonic lesion, and if the polyp size, as I've mentioned, is larger, and if there is intra-procedural bleeding, the chance of post-procedural bleeding is also high. Now, the prediction of lymph node metastasis is in colorectal cancer, especially in early colorectal carcinomas, the lymph node metastasis is difficult to predict. In contrast, invasion and depth can be very precisely predicted by image-enhanced endoscopy, magnifying endoscopy, and endoscopic ultrasonography. So just looking at this, the classification, you can see that SM1 is it just below the mucosa. SM2 is less than, just touches the 1 millimeter the line, and SM3 it goes beyond that. So SM1, SM2 you can go for a EMR, but SM3 you have to go either for a surgical resection, or EST can be tried, but if the muscularis is involved, again he has to be submitted for surgery. But the SM3, the problem is the lymph node metastasis is very high, so it's always better to go for a surgery. So here this again says in SM1 the lymph node metastasis risk is 1% to 3%, whereas in SM2 the risk is 8%, whereas in SM3 the lymph node metastasis is around 23%. So surgery is the best. You should know about certain classification like Paris classification, pit pattern classification, NICE classification, Janet classification, if using NBA plus magnification. Now Paris, you can see that this pedunculated lesions is 1P, sessile is 1S, that's the polypoid lesions. The non-polypoid, you can get minimally elevated, that's 2A, truly flat, that's 2B, minimally depressed 2C, and ulcerated is 3. So you can also see the lesions below. So also the other classification is Kudos classification. I'm not going into the details. So the Janet classification is the type 1, type 2A, 2B, and 3. Here type 1 is a hyperplastic polyps. You don't have to do anything for that. Type 2A is a tubular branched papillary or low-grade intramucosal neoplasia, which can be taken out by EMR or EST. And type 2B is high-grade intramucosal neoplasia with shallow submucosal invasive cancer, which you can go for EST. But type 3 definitely is surgery only because it has got deep invasive cancer. Again, here I've shown the submucosal, how to predict the submucosal. There's a large nodule in the lateral spreading tumor granular type. You can see that polypoid lesions with depressions. These show that it is involving the submucosa. Here also you can see that the depression, you can see in this granular type and non-granular type, both the pictures you can see the depression. So this is invading the submucosal layers. So the rate of submucosal carcinoma depends on the size of the lesion also. If it is less than 5 millimeter, it's very low, 0.1. Whereas if it is more than 2 centimeters, it is 23%. And the non-granular LST is 2 times higher than the granular LST because the deeper invasion. This is a video of a classic, simple video, which is I've taken from the collection of Dr. Raju, G.S. Raju, and it's a very neatly done EMR. First, you inject a dynamic submucosal injection with a lifting solution, which can be anything, but which has to stay for some time. So you can use whatever is available. And then you use a snare, which is, this is a 2 centimeter snare is used here. Catch the lesion by just below its borders, and then close the snare and resect it. So here you can see this lesion is very neatly taken out. You can see that you don't have to clip this lesion because it's a very clean resection. You may not, you don't have to do, but depends on the endoscopist's choice, and can use multiple. And this lesion can be pinned and given to the histopathology. So the lesions for which en bloc resection with snare EMR is difficult, then you need to go. This is an indication for EST when there is LS lateral splitting. LST NG, particularly the lateral splitting tumor, non-granular with pseudopolypoid lesions. Then the lesion showing V1 type pit pattern, carcinoma with shallow T1 SM invasion, large depressed type tumors, large protruded type lesions with suspected to be carcinoma. All this has to go for EST. Mucosal tumors with submucosal fibrosis, sporadic tumors in conditions of chronic inflammation such as ulcerative colitis, and local residual or recurrent early carcinomas after endoscopic resection. You have lots of knives now available. You can pick one of it, and this caps and hoods for endoscopes. This is also lots are available. Then the Quab gas forceps or hemostasis, excellent tool by which you can control the bleeding. This is a standard video of ESD of a rectum. You first see the type of lesion by NBI or chromoendoscopy, and then you inject the submucosal plane and then dissect it. as in the margins, you can see the markers, and when you dissect it, just run the video, you can see the dissection. In between, you can get larger vessels, which can be either smaller ones you can cauterize by the tip of the snare itself, like this. But if there's a larger lesion, a larger vessel, then you have to use the coag forceps and cauterize it. So similarly, the entire lesion can be taken out, and this is how the area looks like. And this lesion can be pinned and given to the histopathology. So coming to the complication, again, perforation and bleeding. Perforation rates are 0.05% in polypectomy, whereas it goes in EMR, it's 0.8%, and in EST, it is 2 to 14%. And delayed bleeding rates 1.6% for polypectomy, 1.5 to 1.7% in EMR, and 0.7 to 2.2% in EST. So technical aspects, you need a CO2 insufflator when you do an EST. Distal attachments, as I've already shown, then the long-lasting submucosal substance like Gelofuse, injecting substances like Gelofusen or lift up or whatever is available. Then devices like dissecting things, and then coag graft, clips, etc. Proper position of the lesion based on gravity and change of patient, and bleeding and hemostasis and perforation. These two are the things which we have to manage. So management of bleeding, I've already shown you some videos. So for bleeding associated with endoscopic resection of clipping or coagulation is required. For a small vessel, as I've already told, contact coagulation with the tip of the snare using EMR, or with the tip of the knife using ESD, or coagulation with hemostatic forceps is usually used for hemostasis. Larger vessels, hemostatic forceps or coag forceps is the best. So this is again a video which shows the bleeding. You can see the bleeding here, and you can use a coag forceps in this sort of bleeding and control the bleeding very effectively. You can apply the pressure with the cap. Temporarily, you can stop the bleeding, and then you can use the coag forceps and completely stop the bleeding. So coming to a perforation, the risk of for perforation in ESD is the lesion morphology. Colon segment, more than the rectum, it's a colon which is the upper part which is going to create problems. Then the larger lesions, and if the submucosal fibrosis. So it's very important. When you don't have fibrosis, it looks very clean. It all look is blue and transparent. That's F0. Whereas in F1, this mild fibrosis emerges as a white web-like structure in the blue submucosal layer. Whereas in F2 fibrosis, when there's severe fibrosis, the submucosal layer appears as a white muscle-like structure without blue transparent layer. Here's the problem. You see this, then you can miss the muscle. See, if you may think that it is muscle and then cut, and then you can create problems, and then you have to close it by clips. Again, this is another perforation which is closed by clips. So colonic wall is thinner than the stomach, and the risk of perforation is higher in the colon than the stomach. So ensure adequate bowel preparation is very important, because good maneuverability of the scope is important. Appropriate device should be available, local injection agent, CO2. And if perforation occurs during the procedure, clipping should be carried out regardless of the location. And clipping should be done after creating sufficient space to apply endoclips, and the position of clip should not impede subsequent submucosal dissection. So if clipping ensures closure of perforation, observe IV antibiotics, keep fasting, watch for features of peritonitis. If CT shows free air, not necessarily always to operate. You can watch the patient, timing for emergencies, watch the abdominal symptoms and lab data. Involve your surgeons at each step. If closure is inadequate or suspicion of peritoneal contamination with bowel is there, surgery should be considered on an emergency basis. So this is just to show how you use this suturing material. These are the areas where you have to use the sutures. You have to put the suture at 12 o'clock position first. It's a marking A, B, C, D, E, F, like that. It is marked like that. And first you put at 12 o'clock, then you go to 9 o'clock position, and then 3, and then to 6, like that. So if you have a suturing, the end of suture, then it's very easy. You don't have to just the B suture. B is put like this. Just so after the all the switches have been put, you can close it like this. And then on follow-up, this is how the lesion, the area looks, and this is a follow-up video. I mean, this thing. En bloc resection is possible in majority of times, and the R0 resection is also in, it ranges in 53 to 90, 88, or more than that, 91%. Local recurrence is less than 3% in, and the procedure-related bleeding is also less. So the post-EST surgery for complications is very, very minimal. So colorectal EST appear to be very effective and safe procedure, at least in expert hands for lesions, otherwise difficult to be radically treated with snare-based endoscopic resection techniques. And the systematic review says that en bloc resection rate is in 90% in EST, whereas in 35% in EMR. R0 resection rate is 80% in EST and in 36% in EMR. And the rate of perforation is around 5% in EST and 0.9% for EMR. Rate of bleeding 1.9% for EST and 2.9% for EMR. So, but there's no randomized head-to-head comparison between EMR and EST, and the need for a large randomized study to obtain unbiased results on effectiveness and safety of these two strategies in patients with large superficial colorectal neoplasm. Just a word about traction devices. This is the clip with line method, and so many traction. The traction creates a tension on the submucosal plane that allows quicker identification of line of dissection and blood vessels. These are the different methods. I'm not going into the details. Another method is the pocket creation. This is this video is taken from Professor Yamamoto's library. This is you first inject the area, I mean the lesion, and lift it, and then you make a, you can see here, you make a small 2 centimeter length incision, and then you create, just like you do a poem, you can create a tunnel. You go up to the end of the tunnel. You can see the line. The above is the tumor and below is the muscles. You have to go in between that. The section of the submucous just above the muscularis is the line, and you completely make a tunnel like that, and then you go to the sides, and then you dissect the cut that area. So you can turn the patient on the gravity. This lesion will come to one side, and you can completely remove it. This is how it looks after the complete resection. So finally, pick the right lesions. Use Janet or Kudo. Pick the right procedure, EMR or EST, and know your limits. It's important. Adequate training and experience is important. Start with smaller lesions. Avoid complications, perforations, and bleeding. And if at all they are there, they happen, then manage with accessories, clips, suturing device, etc. You need to know, and to manage the complications, and need to be these things to be available. And again, worried about the recurrence, strict follow-up is required. As I mentioned, you have to be very, very strict in follow-up in these patients. Thank you.
I would like to welcome our panelists, Dr. Sachin Shetty, Dr. Sethi SK, Dr. Ashutosh Mohapatra, and our chairpersons, Dr. Sanjeev Kar, Dr. Debashish Mishra, and Dr. Girish Pati. If our speakers are ready, shall we take a few questions, sir? So Dr. Amit Kumar Dutta, sir, there are so many classifications on narrowband imaging, like Sino classification, Kudos, NICE, and JNET. Is there any head-to-head comparison among these so many different classifications?
And that's very good, very relevant question, actually, because obviously, you can't remember so many classifications, but essentially, if you look at the details of classification, what they're looking at is they're looking at the surface, the vascular pattern, and some morphological aspect. Okay, so head-to-head, not too many, but I think basically in Japan there are quite a few, because that's why it's used very frequently. But outside of Japan, what is popular is the NICE and the JNET. The thing with JNET is because NICE in the type 2, they have clubbed together different types in one bucket, and some lesions may not be good for EMR, they may need EST, some so like that. That's why JNET is what probably practically the good classification. But however, even JNET, if you look at the once the classification is done, there are some real-time validation studies in clinical practice. How good does it perform? And in those studies, it's again 2A, 2B. it's not very great discrimination. So as of now, I think NICE and JNET are the ones, and JNET is preferable to know. Head to head, as such, I'm not very sure, but there are not too many, is what I can tell you actually.
Also, to practically follow the things, see, in JNET they use high definition optical zoom colonoscopes, whereas in NICE it is only high definition endoscopes. So I mean, practically more NICE is more practical to use than the JNET till we get that optical zoom colonoscopes everywhere.
Yeah, see, I think if you ask me, that is not a big limitation, because if you look at the endoscopes, see, optical, digital, there is a little bit different in terms of zoom part, but even optical, even the digital zoom which we have is giving you a good amount of magnification. Okay. Now, obviously, the older, the 180 series, it was not very great, I must agree, but the newer, the 191 is quite good actually. And what you are interested in knowing the morphology of the pit, like tubular or branched or not. And that I think is quite easy to make out both on, I think on the digital zoom as well as optical. I think the optical scores over digital in terms of the vascular, the vascularity is slightly more easier to appreciate in the optical system. But for practical purpose, for the real-time management of patients, a 190 HD is, I think, to me almost as good in most cases because I have used optical zoom when I was in Japan. And obviously you get a much clearer image, but for practical purpose, look at the branching and the tubular nature and all. The 190 system is quite good. So I think the main thing is to be familiar and keep using it rather than the technology. That's what I would say.
Okay. And also to predict the depth of invasion,
yes.
After suppose if you do the EMR or EST of this lesion, will your pathologist will be able to tell the depth of submucosal invasion?
So there again, I think it all depends on how we put the specimen and send it to them actually. Because so I think if you look at the Japanese, the way they do it, that's how we should also do it. Is when you retrieve the specimen after dissection, it should be mounted properly on a flat surface, usually a thermocol thing, and the pins to stretch the edges. And I think submucosal depth is the key information you need, because if submucosal information you don't get, and if it turns out to have some carcinoma in any part of the lesion, then you don't know whether your margins are good. So therefore, I think the submucosal depth is a very important aspect the pathologist should give you. But you should mount the specimen properly and send it to them, and and you should ask them for that information, which I think mostly they will give. That's what I would say. But again, in centers where you don't do it frequently, they should not confuse it with a routine. Even a routine polyp, we need to know the margins and all. But there, I think there is a cautery defect and stuff like that. So here you should have a good margin and ask the pathologist to tell you about that, and that's an important part of management.
In ulcerative colitis, suppose we are seeing a pan-ulcerative colitis, you can skin the any small malignancy in NBI mode. Whether it is easy to skinning whole colon with NBI mode or with skin part by part, or whether there is any suspicion of the lesion.
So that's again a very good and very practical question. Now, just remember two things. One is that you are doing NBI for surveillance. So somebody has an active disease, do not use NBI. You'll get confused. Everything is inflamed, ulcerated, and you'll have. So one thing is disease should be in remission. That's first step. Okay. Second thing is the lumen of colon is not as big as the stomach. So lumen is a bit narrower. And with the newer systems like the 190, the visibility is much better. So earlier we could say it was actually what you're saying is right. If you do straight away NBI, and if they're not very good vision in the lumen, you may miss things actually. So ideally, it should be that you should do a white light, and then you should switch to NBI. So maybe you've gone to CECUM, you do a white light after ascending colon, go back, do NBI. But with the 190 system, the illumination is quite good. So you're doing in a patient disease in remission, no active lesions per se. You're trying to pick up subtle lesions. Doing a 190 per se also is okay. Or even you can do a white light and then do this thing, because the illumination with the 190 system is quite good, as I can tell you. And it's not a problem thing in a remission patient, because there you're not having a lot of these lesions of ulcerations and erythema. So it's more easier to do it in a remission patient for surveillance. Whereas an active patient, there's not much role of NBI.
Suppose in a patient with ulcerative colitis, we are getting a low-grade dysphasia or high-grade dysphasia, whether we for the EMR or ESD, how it is possible?
So again, if you look at the recommendations, if you have a high-grade dysplasia, ideally you should go for a colectomy also, because this is like a field. It's not like one lesion which you have picked up. So the recommendation is those patients should be sent for a surgical thing. But then you'll come across patients who do not want to go for surgery. So in those patients, the option you have is an ESD. You do an ESD and then you keep them under very close, maybe annual surveillance, not even like every yearly you should do. So basically patients with high-grade dysplasia, you should recommend a colectomy. If they don't agree for it, you do a dissection ESD. Make sure the margins are well covered. and that patient should be on a very close surveillance subsequent to your therapy actually. Low grade dysplasia, a bit more you can do it, but high grade, even my patients, I prefer to send them for surgical thing. If they refuse, because the problem is not that one lesion you picked up, it's the other lesions surrounding and the risk of malignancy. That's what. Okay.
Thank you.
Yeah.
So next question is to Dr. Rai Mukkada. Sir, when you do the colposcopy and when you are finding the polyps, in the same setting, do you want to do the EMR or ESD, or you will come out and later you will plan for this procedure? How exactly you will plan?
Usually, when we prepare a patient, we take a consent for polypectomy. If you see, and also we do an investigation like INR, sodium, potassium, and hemoglobin and platelets. These things are standard for any colonoscopy, and we'll tell them that if you see a polyp or something, we'll go ahead. We get the consent also, because otherwise it's too difficult to come. The patient again coming maybe from a long distance. So always get a consent before that. That if there is anything, we will go ahead. Otherwise, better to do some investigation, basic investigation also.
And what are the imaging studies you want to do before doing ESD? Will you routinely ask for CT scan before doing ESD? Yeah. Or you are based on NBI?
You think that ESD, I feel that it's always better to have a CT scan, because you need not get, but sometimes, now the lots of medical legal, so the problem with ESD is you require a long-term follow-up, and we have to have a very close follow-up. If somewhere some lesions we are missing, then it's a problem. So before you jump into an ESD, I feel that we should get a CT also. What do you think, Amit?
Yeah, I think, at least for me, obviously, so like for me, EMR and polypectomy, if it's an ESD, I would normally not do I'll do it in another setting. The conversation becomes a bit different. So EMR polypectomy straight away. ESD, as you said rightly, the patient's communication, and then maybe a scan, because even the rectum, because this is rectum and sigmoid is where we normally do these. And we need to know the sort of depth, and also CT or MRI is sort of quite good. So I also would probably, if it's an ESD-like lesion, I would sort of not do it in the same setting. Talk to the patient, get an imaging, as you were saying. Because US, again, we don't have too much of experience, and I think the CT is much better for lymph nodes and all the surrounding, actually. So we would do the same. That's what so I will agree with you, sir, what you're saying.
Hello, sir. How do you manage the recurrences? Sorry. Yes, sir, please, sir. Dr. Girish is online.
Hello, I'm Dr. Girish. My question is whether there is any role of artificial intelligence to differentiate different varieties of lesions in the current era. Now it is growing like anything. So what is the role of now NBI and artificial intelligence? How could we go differentiate? And another thing is whether there is any chance of US rectum, and if it could be go to colon, but US rectum to differentiate between different types of polyps, to differently submucosal extent and mucosal extent. So
the NBI question I can answer. US Dr. Roy, I can give it to him to answer. So the NBI, what you said is very right. The problem, see, all this image enhancement, you have so many types of NBI, eye scan, PICE, etc. And the thing is, you are having such magnified image, structure, surface, vascular pattern, etc. And for a human eye to really, decipher everything and know what's going on is not very easy. So there's a lot of interest, huge amount of interest on artificial intelligence. And I think it's just a matter of time before it starts becoming a part of the routine, software package of your image enhanced endoscopy. But that definitely is going to be the thing of future. Otherwise, the application will only, increase once people are able to use it with assistance of an artificial intelligence to know what the lesion they are seeing. Right now, not ready for prime time. I don't think anybody is, but then a lot of work, and I'm sure soon it will be available. US Dr. Rai, you want to comment on the US part?
Yeah, US is a good tool, especially in the rectum. That's all we can do. But the problem is you need to have a dedicated rectal because that's one problem which we are facing now. We don't have the dedicated scope for that. Otherwise, we have to use the other scope, but that's not very. So we don't usually do. We don't prefer that. So if there is any other imaging modality that's available, we go for that, either MRI or CT scan rather than EOS. But EOS is a very good tool for the rectal lesions.
And cost also is not too much difference. I think MRI gives you much more information. MRI gives you much more information. That's the reason why I think it's not that popular to use EOS, because EOS gives you limited information. MRI can give you much more. And I think, as I said, patients have to, be told that this is not for surgery, this is for this thing. So even for us, we prefer to do, even though that Pro we hardly use, we have it. We prefer to do MR or something in such patients.
Exactly. Sir, another
Right, please.
really
Hello.
very wonderful presentation, both of you. Sir, whether I should go for CCT pelvis instead of MRI pelvis or MRI pelvis instead of CCT pelvis, which one is better and how better, sir?
That's a debatable thing. It depends on the experience of the radiologist in your institute, because sometimes we feel that CT is better in many ways. But if you think that there is, I don't know, if it is some other disease like a fistulous disease or something, we go for MRI. But for a lesion like simple lesion, I feel that the CT scan is better, because fast, cost-wise also, and the radiologists, most of them will be experienced in reading a CT rather than an MRI. So it all depends on the center where you work and your experience, radiologist experience also. What do you think?
Yeah, I mean, true. I think for us, we prefer, because our colorectal guys prefer MRI, and as you said, image quality also. It's not only the image quality also matters so much in MRI. Any artifact can give you a lot of problem, unlike a CT. So good image quality, good radiologists, all that factor. So it's not a straightforward thing like which one. And like what Dr. Roy said, people are much more familiar with a CT scan than an MRI. It's like quicker. So both are okay. I mean, there's no, especially for us, we are more of an endoscopic therapy. We are not dealing with those extensive disease.
Yeah.
I think it really may not be too. So finally, even after EST, which you do, if your base is clear, that is your most important part of staging. If when you do a specimen dissection and you send to pathologist, the result you see is like also part of your staging only. If it's the edges are free and clear, you've done a therapy is done. That's what you take it as a final part of your procedure, actually.
Right.
Right, please. How will proceed for second part of duodenal polyp? In the polyp in the D2, how will proceed?
How? Pardon, I can't hear you.
Proceed. Whether we proceed, will proceed for the how to treat?
Yeah, again, it's a second part of duodenum. The ESD is a little tricky and highly difficult, and most but you can do it. Definitely, there is no problem in doing, but you have to be aware of the complications, and you need to tell the patient, and you should be very ready to tackle the complications. Also, if there's a perforation, you need to have clipping of all modalities, including an OTSC clip. Sometimes the perforation may be bigger one, because this is what happens in the duodenum. The perforations, the chance of perforation is very high, and also bleeding. So these two things you have to tackle. And otherwise, you can proceed with an EST or EMR. That's not a problem.
So after the EST, is there any way by which we can make out that there can be impending perforation or delayed perforation can happen in that particular patient? Is there any markers or predictors for that?
Usually we see that target sign if there is some areas wherein which looks, the muscle layer is very, exposed, or the target sign is there, then we prefer that to clipping is better in order to prevent the late perforations. Again, the bowel preparation is very important when you do any procedure. Otherwise, will contaminate. If at all, if there's a perforation, it's not a big problem. You can most of the times you can do a clipping. But if the bowel is not prepared, it can contaminate the peritoneum, and it can cause a lot of. Then you may have to call the surgeons. So you have to be very. That's one important thing. You have to be very, very close with your surgeons, because anytime you can create problems. And so
routinely do you consider clipping of all after the EST? Routinely you do it?
No.
Closure of the...
Only if there is any doubt of perforation, or you think that there is an area which is exposed or something like that.
Okay. Because in Japan, especially ascending colon for this thing, ESD, routinely they do clipping. That's what I observed.
Colon, that's a difference, because the chance of perforation is high, because not like rectum. If you go higher up, then the chance of the perforation is very high. So that may be the reason it's better to do a prophylactic clipping.
And how frequently you follow up the cases after the ESD, and if there's recurrence up there, how will you manage those recurrences?
Yeah, that is a good question. See, if there is this is especially so with EMR. So if you think that you've done a piecemeal resection, then you need to have a very close follow-up. 6 monthly at least for some time. The the follow-up should be there. ESD also, it is always better to have some close follow-up, because in case we miss something, this somewhere recurrence it is happening. It's better to have a 6 monthly to yearly follow-up. I would like to have Amit's opinion also here.
Yeah, so I think first one after 6 months, and then probably annually is what we do actually. First one is after 6 months, because it's more of leaving behind thing in that area. With the initial cutting, you don't know something, but after the first one, it's usually annually is what we sort of do for our patients. Yeah. And again, we do EST up to maximum rectosigmoid. We really don't go beyond that, because it needs more explicit. The thing is, our case volumes are not that much, So you need to have volumes to this thing. So really, anything beyond rectosigmoid, we give it to the surgeons to handle is what we do actually.
I think sometimes we will be taking a lot of headache, because I sometimes feel why we should take so much of headaches. We can give it to the surgeon and easily they can do a very neat surgery. Why we want to try out this thing?
And even if you think of a cost, if you look at the cost part of it also, if you look at the devices of this thing, a laparoscopic surgery actually, again, there will be differences in different centers, but sometimes I feel the EST, the devices, everything, sometimes cost may come close to a laparoscopic, and there you go, nice resection and do this thing. So obviously you avoid invasive sort of incision also. Rectosigmoid is okay. But beyond that, if you're a high volume center, a lot of experience, a lot of cases, fine. But otherwise, you have to be cautious.
When you're doing the surveillance scopy, do you take the biopsy from the scar area of the previous ESD site, or in general? Routinely you take the biopsies?
Not routinely, but if there is any suspicion or any areas, I think it is better to take once you have done an ESD, I think there's no problem in taking a biopsy. What do you think?
Yeah, only if it's for us, only if it's suspected. Otherwise, if it's a scar alone, you can make out pretty well that's a scar tissue. Yeah. But if there's any nodularity, irregularity or something, even a small polypoid thing coming up, we do take biopsies from that. But if it's like absolutely clean, just scar, we don't do biopsies.
Sir, in neuroendocrine tumors, will you do ESD in them generally, in the gastric as well as rectal? Neuroendocrine tumors.
Again, it depends on your other imaging modalities. So routinely, if you think that it can be done, it can be done. That's not a problem. But you have to have very proper other modalities of imaging. Otherwise, you should not do it. Because I feel that this is again the question is the cost is a big thing. Even surgically, they can do a very good job. Neuroendocrine and all, you can have a very excellent.
Yeah, I think especially stomach, neuroendocrine. Initially, people are doing a bit more because that's what you see more than early gastric this thing, and then you realize that the submucosa is not very clean. The dissection part of that entities, you don't get a very good feeling because you can see the burning also. So the plane of dissection which you see in a gastric cancer is not as good in a NET because they are not truly epithelial. They are a little bit of this thing, and I don't know whether so that's why for NET we also hardly do. Earlier we had done initially, but we don't do much of NETs.
Thank all the speakers and also the organizers for giving me the opportunity to moderate this session. Thank you so much, sir.
Thank you. Thank you.
Thank you so much. Thank you.
We'll wind up the session. Thank you very much.
Thank you. Adios. Thank you.
Thanks.